Hello.
Hello, madam, am I audible?
Yes, you're audible now. Start, sir.
Mouse.
Good morning. The topic is Rapido trial. What I will try to present today is hello.
You're audible.
Hello.
Gina, you're audible.
Madam, am I audible now?
Yes.
Okay. What I will try to present today is make everybody to familiar with what is the Rapido trial and what all were the results of the Rapido trial and which all are the trials similar to that of Rapido trial, and to examine whether the results of this Rapido trial can be done in our hospital also, and I will try to get a conclusion. And starting with the standard answer, what we usually do for a locally advanced rectal cancer is neoadjuvant treatment, neoadjuvant radiation along with chemotherapy, that is concurrent chemoradiation, followed by total mesorectal excision or partial mesorectal excision, and followed by. But this surgery is not a standard, and it is not followed in all nations. And it is the role of adjuvant chemotherapy is not established in case of a locally advanced rectal cancer. So the local recurrence rates has been reduced by this mode of treatment by the standard of care to around 5 to 9%. That is with the neoadjuvant chemoradiation followed by surgery and adjuvant chemoradiation. But the distant metastasis and hence the overall survival has been the same since several years. So the interest is the point of interest is to reduce the distant metastasis and the rate of incidence of the distant metastasis and the improvement of the overall survival. So various modalities, various combination of treatment has been tried, and one among that is the Rapido trial, that is today's topic. This is a randomized control phase 3 trial, which is conducted in 7 nations in 54 hospitals, and which is mainly coordinated by the Clinical Research Center in Netherlands, which is recently published in December 7 in 2000. The recent last results are published in December 7 in Lancet Oncology, December 7, 2020. So and this is conducted from we started in 2000. The recruitment started in 2011 and over in 2016, and they have recruited a total 920 patients, and there were these patients were grouped into the experimental group consisting of 468 patients and the standard of care group, 452, total of 452 patients, and a total of 4.6 years of median follow-up was over in June 19, 2020. The hypothesis that led to this beginning of this trial was that following the short course radiotherapy, a delay is possible, and which will not cause any significant difference in overall survival in locally advanced rectal cancer, and it can be followed by safely by a surgery, which is already proved by the trial Stockholm 3 trial. This is the Stockholm 3 trial made the basis of this Rapido trial, which proved that a delay after short course radiotherapy for a locally advanced rectal cancer is possible and can be done safely for a locally advanced cancer followed by surgery, and which with this can possibly potentially reduce if this delay can be used for giving neoadjuvant chemotherapy, which is not usually done in the standard of care, in the present standard of care. If this delay can be used for giving the neoadjuvant chemotherapy, this can potentially reduce the number of distant metastases without increasing the risk of locoregional failure and ultimately improving the overall survival. This is the hypothesis they made, and they examined this factor by dividing these patients into two groups. And the inclusion criteria were patients more than 18 years and locally advanced rectal cancers. And they made a stringent MRI criteria for recruiting the patients. That is T4A or T4B clinical stage patients with extramural vascular invasion and the clinical nodal stage N2 with mesorectal fascia involvement and enlarged lateral lymph nodes that are considered to be metastatic. These are the patients which are recruited, and the exclusion criteria included extensive growth, which is inoperable, and patients with metastatic or recurrent rectal cancers. And coming to the randomization, they have divided the patients into experimental group and a standard of care group based on several factors, including institution, performance status, and the clinical T stage and the N stage. And this is the model of the Rapido trial. They have divided the patients into two, and the first one is the experimental group. That is, this bar represents the short course radiotherapy, and followed by 11 to 18 days, followed by neoadjuvant chemotherapy, that is, which lasts for 18 weeks. That can be either 6 cycles of capox or 9 cycles of FOLFOX, then followed by 2 to 4 weeks of followed by the surgery. And this is the experimental group, and which is compared with the standard treatment group, that is neoadjuvant chemoradiation of 5.5 weeks, then 8 weeks of gap followed by surgery, then followed by the adjuvant chemo. But this adjuvant chemo can be optional. All the patients didn't receive the adjuvant chemotherapy. This can be either capox of 8 cycles or FOLFOX 12 cycles according to the institutional protocol. This I have already mentioned. The experimental group short course radiotherapy 5 into 5 grays, 5 fractions, and followed by 6 cycles of capox or 9 cycles of FOLFOX is given, then surgery after 2 weeks. The standard treatment group is radiotherapy 28 fractions 1.8 gray, total of 50.4 gray, either, or 25 fractions 2 gray for a total of 50 gray, along with oral capecitabine, followed by 6 to 10 weeks of followed by surgery and adjuvant chemotherapy, which is optional. That is 8 cycles of capox or 12 cycles of FOLFOX within after 6 to 8 weeks. The surgery is the total mesorectal excision or a partial mesorectal excision according to the site of the tumor, and it can be either open or laparoscopic. coming to the results of the trial, the primary endpoint they mentioned initially was the disease-free survival, but later they have changed it to the disease-related treatment failure. And the reason for changing of the primary endpoint I will describe later in the later slides. And the description of disease-related treatment failure, where the locoregional either a locoregional failure or a progression of the disease into an unresectable tumor while on neoadjuvant treatment, or a locally unresectable tumor during surgery and a local recurrence after an R0 or R1 resection, or it can be a distant metastasis, or it can be a new primary colorectal tumor, or a treatment-related death. These are the primary endpoints. And these are the total table showing number of patients in each group. Totally 920 patients were there. 468 in experimental and 452 in standard of care group. And eligible patients were 462 and 450. Started allocated treatment for 60 and surgery with curative intervention. Intention was done in 423. Followed by adjuvant treatment was given for only for 187 patients, and 211 patients did not receive any adjuvant chemotherapy. Then the quality of life questionnaires were filled by a total of 274 patients in experimental group and 243 patients in standard of care group. Coming to the various results of the trial, this is the major result, that is they have got the disease-related treatment failure. This is the primary endpoint they have looked for, and this is 23.7% in the experimental group and 30.4% in the standard of care group. That is around 7% difference in disease-related treatment failure. The advantage they observed in experimental group, and most of the disease-related treatment failure was due to distant metastasis. That is 67% of the disease-related treatment failure was due to distant metastasis. Most of them are due to distant metastasis. But one thing is the local recurrence that we can see here is more in the experimental group, and that is 17% in the experimental group and the 10% in the standard of care group. Coming to the pathological response, that is the complete pathological response is observed in 28% of patients in the experimental group, and 14%, that is double the result of double the number is observed in experimental group. That is significant in statistically significant. This is the same thing. Disease-related treatment failure was seen in 23 and 30%. Cumulative probability. This is the cumulative probability of distant metastasis. Cumulative probability of distant metastasis is higher in, that is 7% higher in case of standard of care group, and the cumulative probability of local regional failure is higher in case of the experimental group. This was not actually statistically significant, and this is to be considered in the context of one thing, that is in standard of care group, patients received actually better local control, that is by surgery, better total mesorectal excision specimens where they are in standard of care group. Even after that, this was less in case of standard of care group. Coming to the toxicity part of the trial, more than the grade 3 or higher toxicity was observed in around 48% of patients in the experimental group, and that was significantly less in case of standard of care, that is 25% in the standard of care group. Those patients which have received post-operative chemotherapy in the standard of care group, when it was considered, the percentage was 35%. Toxicity most commonly observed in both the experimental arm and also in the standard of care arm was diarrhea. Coming to the number of deaths that was observed, total of 161 patients died in total 3 years of follow-up, and that was 80 in experimental group and 81 in standard of care group. And the rectal cancer related death was 79% in experimental group and 82% in the standard of care group. And this was not significantly different. And there was no overall survival benefit was observed in case of this experimental group and compared to the standard of care group. This is the chart showing the overall survival, which we can see the graph is overlapping most of the time and is not significantly different. Coming to the discussion, and significantly lower probability of disease-related treatment failure is seen in experimental group, and the reasons for that are the following: because of decreased rate of distant metastasis, which is observed, maybe due to better treatment compliance by the patients for the chemotherapy that is given in the pre-operative setup, when the patients were the general condition was more better than when compared to the post-operative setup, and fewer weeks of chemotherapy when compared to post-operative adjuvant chemotherapy, that is total 18 versus 24, and the early start of chemotherapy, which can deal with the micrometastasis which may be present, which can reflect the decrease in rate of distant metastasis. And pathological complete response rate was double that in when compared to the standard of care group. And this experimental treatment offers the potential opportunity for patients who are seeking for an organ preservation, that is no surgery, can be considered as the percentage of pathological complete response is high. We can think about watch and wait and watch policy in this experimental group. This is the timeline showing various trials which are dealt with the treatment of adjuvant and neoadjuvant treatment for locally advanced rectal cancers. The most recent one are the Rapido and the Product23 trial, which both of them dealt with the total neoadjuvant therapy. And the previous one was the Stockholm 3 trial that was published in 2019, which I already mentioned, was the delayed the effect of delaying surgery after short course radiotherapy. And previous to that, the notable trials were the German trial, the NSABP R04 trial, and the Polish 2 trial, and also the Dutch trial in 2001. Coming to the similar trials, some comparison will be appropriate in this setting. That is 3 trials which dealt with the neoadjuvant treatment for locally advanced rectal cancer. First one is the Polish 2 trial, which is an older one that was published in 2006. This also, in this case also, they have divided the patients into the neoadjuvant treatment, neoadjuvant chemotherapy of FOLFOX 3 cycles, and when compared to the chemoradiation followed by surgery group. And the distant metastasis, when compared to that in the Rapido trial, this 20 and 26% we got in Rapido trial. These numbers were 30 and 27% in the Polish 2 trial. And the possible explanation for the difference between the 2 experimental groups in between the Rapido and Polish trial may be the preoperative chemotherapy duration, which is 18 weeks in case of Rapido trial, and here it is only 3 cycles are given. And there is also there is no difference they have observed in when compared with the standard of care group, that is post-op complications the ancestral resection rate, the late toxicity, the disease-free survival, and the pathological complete response was seen in 16% in case of short course and 12% in case of long course chemotherapy. Coming to the Stockholm 3 trial, which examined the role of delaying the surgery after short course radiotherapy. There were 3 arms. First one is early surgery, that is within 1 week after short course radiotherapy. Then the delaying surgery 4 to 8 weeks after short course radiotherapy and neoadjuvant chemoradiation followed by surgery. When compared to the Rapido trial, the pathological complete response was 28 and 14. In Stockholm trial, the numbers were 10 and 2.2%. The reason for difference may be the longer interval and addition of chemotherapy in case of Rapido trial. And this actually formed the base for the PRODIG and Rapido trial, that is the delay in short course RP, which is safer following the short course radiotherapy. Coming to the PRODIG 23 trial, which is also published recently, which is actually going on, and the results are awaited. The randomization was like this. The neoadjuvant chemotherapy was actually more intense than that of Rapido, that is triple agent FOLFIRINOX was given 6 cycles for 3 months, followed by radiotherapy, and then for 6-7 weeks delay for surgery and adjuvant chemotherapy. And the standard of care, the usual group is the neoadjuvant chemoradiation followed by TME and adjuvant chemotherapy. Here we can see in the PRODIG trial, the pathological complete response was seen in 11% versus 27% in case of standard of care group. And the disease-free survival was also, the 3-year disease-free survival was 68% and 78% when compared to the standard of care group. This is also showing the comparison between Rapido and the PRODIG 23 trial. The median follow-up was 4.6 years and 3.8 years in PRODIG 23 trial. The primary endpoint in case of Rapido trial is the disease-related treatment failure, and here it is disease-free survival. And 3-year metastasis-free survival was 80 and 73%. Here the numbers are 78 and 71%. Pathological complete response is double in case of Rapido, and it's almost a triple in case of PRODIG trial. And local relapse is 8.57% and 5.4 and 4.8 and 7% in case of PRODIG trial. These are the some comparison between Rapido and PRODIG 23 again. These are the principal investigators of Rapido and PRODIG 23 trials. The inclusion criteria for Rapido trial was more selective and stringent criteria with an MRI criteria was explained in Rapido, but the inclusion criteria was less stringent for that of PRODIG 23 trial. Adjuvant chemotherapy was optional for Rapido, but it was mandatory in case of PRODIG 23 trial, and NACT was more intense in case of PRODIG 23 trial. Coming to the advantages that is observed in case of Rapido trial, this decreases the disease-related treatment failure by reducing the probability of distant metastasis and the higher rate of pathological complete response. Coming to the limitations of this trial, first one is the change of the primary endpoint. That is, initially they have mentioned the primary endpoint as the disease-free survival, but later they have changed the disease-free survival into disease-related treatment failure. And the reasons they have mentioned for that are following. That is, this disease-free survival endpoint is used as it's an endpoint usually used for adjuvant trials, and in neoadjuvant trials it is inappropriate to use a disease-free survival as the endpoint, because the patients are not disease-free until patients have undergone a curative surgery. So patients are having a long waiting period before they undergo a surgery. So this is the explanation they have given. The patients undergo surgery only after a long period of duration. So it is not appropriate to put disease-free survival as the primary endpoint. So they have changed it to in the disease-related treatment failure while the trial was going on. And the second limitation was that there was no centralized review of baseline MRIs, which can lead to an understaging or overstaging in different institutions over different nations. This is the summary. We have already seen that there is a 7% lower disease-related treatment failure, 7% lower distant metastasis rate, and doubling in pathological complete response rate, and similar overall 3-year survival, that is around 89% in each group. And there is no increase in unexpected toxicity rates, and no difference in surgical or post-operative complications or quality of life. Coming to the Center for Evidence-Based Medicine critical appraisal tool, and the most valid question that we should ask is these 3 questions. Will the result help me in caring for my patients? That is the external validity. Can it be applied in our institution? Is my patient so different to those in the study that results cannot be applied? And in our institution, we see most of the rectal cancer patients are in locally advanced rectal cancers with T3N+ disease. So most of the patients are similar to that of the patients we have seen in this study. And is this treatment feasible in this setting? We have to examine that. And will the potential benefits of treatment outweigh the potential harms of treatment? The toxicity profile, we have to examine how much this toxicity our patients will tolerate or not. One thing is the heavy chemotherapy in the neoadjuvant settings cannot be offered for elderly patients. This can be given for comparatively elder patients, and can be tried in our settings also for obtaining a better overall, better disease-related treatment failure, and better outcome for locally advanced rectal cancers. Thank you.
Gino, am I audible?
Yes, sir.
Gino, I think the issue for us here, sitting in India, is something beyond the comparison of short course radiation with adjuvant, because Netherlands, they have very clear-cut management where mainly they rely on short course. But we have been, since then, if you look at many of the trials, I think the long course trial also was published during the initial Stockholm trials and Dutch trial. Then we started believing long course radiation, and some part of chemotherapy is given upfront before surgery. But for us, it is little more complicated than them, because we have to decide whether to go for a long course, whether to go for a short course, or then give chemotherapy upfront or later on. And the time-tested method here is long course chemorad followed by surgery and maybe adjuvant treatment. So in that view, what is your opinion about shifting from this pre-operative, post-operative chemotherapy to pre-operative chemotherapy? I know simple because the issue is little complicated for us, because we have been relying on other. For a person in Netherlands or Europe, it's very clear cut. They want to give radiation to short course, and they started giving it, and now they are trying to bring chemotherapy. We are a little more complicated because we believe in American school of thought, and we used to give long course chemo, and now we have various options to choose. So that will make things a little more complicated for us. Why everybody silent? Nobody can. Am I audible?
Yes, sir.
Yeah, Meera, tell your opinion. Meera, what is your opinion?
We don't know. We have to see how many patients can tolerate the toxicity of entire treatment given upfront and
Is it what happens with the short course patient regime? Is it okay for patients? I think there are divided school of thought. I think some patients are doing good, and some people, I don't know what's the result. So what is our experience with short course radiation?
I feel once in a while we do get patients in whom surgery becomes very difficult.
Yeah, I think, but all those patients are immediate surgery.
That has to do with the timing of short course or what? But once in a while we do get such patients.
I think somebody has to look into it, because most of the radiation, they're doing their own studies and thesis like that. But what is being reflected in surgical morbidity and surgical difficulties, I don't think they are quantifying it. We should just go through the maybe 20 or 30 files which when in which patient receives short course radiation and decide. Because long course is the time trusted tool. So before changing anything, I think we have to be really sure about at least no harm is being caused by this short course radiation. Gino Boyo.
In between I missed you. You were saying something.
Yeah, he's not at all. And I think his critical appraisal is short, just stopped with one slide. I think he should have done a little more. The critical appraisal of a journal starting from sample size, things should have been different, a little more.
No, he's not logged in only. I think they all got logged out.
And one more thing I'll tell you, now the whole world thinks about, especially in Europe, the uselessness of chemotherapy in rectum. They, when they analyze huge databases, they found out that the other than surgical radiotherapy and other than surgery, the contribution of chemotherapy to the rectal cancer cure is much less. So that also we have to be taking into consideration when embarking on believing something upfront before surgery, because all this will add up to the morbidity of surgery, I'm sure. It may not be happening in Europe, but if it is, if you do the countrywide change in practice in India, giving radiation, chemotherapy, and everything, and there may be a significant subset of patients who are not going to behave very well with the surgery. And again, the umpteen number of trials have shown that first of all, the chemotherapy is less useful in rectal cancer, and second is even if the patient did not receive the full prescribed doses of post-operative regimens, even a couple of courses of chemotherapy is good enough, or even not much difference between full course and short chemotherapy. So those things are also have to be taken into consideration. And we should also believe that a patient who is not behaving very well after surgery and not completing chemotherapy is also part of their natural biology tumor, which had a significant take on this issue.
No, it's come back.
He comfortably disappeared and came back. I don't know, nothing for him to answer now. Yeah, moderator, I don't know.
It was being class only.
Yes, tell something. Okay. Find up.
Gina, can you hear anything? We'll wind up.
Okay.
Okay, thank you.